Good afternoon, everyone. Thank you for hanging in there. We got the Roundup music going. This is the final Roundup. Everybody capture the QR. All right, we'll go on to the first question. I hate to turn it down, but here we go. Let's see. All right. You were asked by the ED, they call you directly to see a 10-year-old with a 4-day history of abdominal pain and a white count of 18. Somehow they got the white count before they called you. And you tell them, I'll be right there. You tell them, I'll send the resident. You tell them, go ahead and get an ultrasound. You tell them, how about go ahead and get a CAT scan? Oh, no, these days, let's go ahead and get an MRI. So I want you to tell the truth, tell what you'd really do. What? So ultrasound would happen before they ever called you. Yeah. Now I see a lot of heads going up and down there. Yeah.
Mac.
Yeah, bro.
Can I pose an offshoot of this question to the audience? I'm curious, if you have a 10-year-old boy that comes to the ER, 2 days of pain, first started to the umbilicus, went to right lower quadrant, nausea, vomiting, white count 18, you do an exam, focal right lower quadrant tenderness. Who in the audience would just go to the ER with no imaging? Anybody willing to talk about that? Oh, the hands went up, then they went down. Someone's got to be right. I like this lady right here. She's going to tell us why.
10-year-old boy with the classic symptoms, what else is it? I mean, if typically, like everybody else who nodded their heads, the ED got the ultrasound before they called me, but with that history, that's enough.
All right, yes.
Oh, there's another comment right here.
Same comment, similar comment over here.
So I would go, except for the fact that the parents often, ask for imaging, and they put some pressure on you to do something. Are you sure?
All right, we're going to keep going. All right, so in this case, you're going to diagnose appendicitis with the 5-centimeter abscess. I know that wasn't quite the story, but let's pretend. So now you admit, start IV antibiotics, and what do you do? What's your plan? You're going to go ahead and do an early appendectomy, antibiotics only, and maybe this patient never needs an appendectomy. Drain and antibiotics only, never an appendectomy, or the triad, drain, antibiotics, and plan for an interval appendectomy.
How many days was it, Mac? I'm hearing that back here. How many days of pain?
We'll say 7.
7 days.
Thank you. All right, well, some are going to go to the OR, probably not in the middle of the night, but next day. And some are going for the PERC antibiotics, but still take out the appendix. Not many people have latched on in this scenario to just treat with antibiotics. All right. Let's say you fall into that group that does the early appendectomy. The patient is doing well post-op, and now you've got to figure out how much antibiotics to give. Do you do early discharge, say the next 24, 48 hours without any oral antibiotics because you've taken out the appendix and washed out and given IV antibiotics? Early discharge, but you're going to complete a course of, say, 7 to 10 days of antibiotics total. Keep them in the hospital for at least 48, 72 hours on IV antibiotics, and then discharge them home, and this time not on any oral antibiotics, or 72 hours of IV and then home to complete a 7 to 10 day course. This seems to be something that we argue about a lot.
I hear some people over here saying their option isn't available. So I was wondering if I could call here on Emily to see her comments.
So at CHOP, we adopted a clinical pathway where they go home when they're eating a regular diet and they're having relatively normal bowel function and they're afebrile and sort of clicking all the clinical boxes. We keep them on IV antibiotics until they hit that point, and then they go home with no further, irrespective of how long they've been in the hospital. With the scenario that you just gave us, I think it's pretty doubtful that this kid's going to be ready to go home much before 72 hours, but once in a while you have that kid who looks really rosy and surprises you. And even though it feels wrong, we'll send them home, after 48 hours of IV, and we have not found that practice has changed our rate of, coming back with an abscess or any such thing.
Katie, we got a comment from my side, and since it's from my side, it's going to be even better.
Ooh.
Oh, that was challenging words. So we have something very similar where they have to kind of meet all of these criteria, but really it's just making sure that they are drinking enough to stay hydrated. They've started to eat, knowing full well that they're probably not going to be eating their regular normal diet quite yet. That they're afebrile, they're not vomiting, and their pain's well controlled. And so they'll be on IV antibiotics up until that point. And then however many days left that they have of the 5 days of total antibiotics, the rest of it is PO, Augmentin, and then that's what they go home on.
So that's kind of like a stop-it trial algorithm, except for maybe 1 extra day. So basically 5 days of antibiotics. Elizabeth, does this sound familiar to you? Or did you miss it? No antibiotics at discharge. That's what these guys are promoting. That's what we're doing.
Okay. We'll go to a different case. You're called to see a full-term newborn with a large left CDH. She's on full support, but hemodynamically doing okay. You have the first 2 things to decide, choices. We're going to continue to treat you medically and wean from support. I had an attending at my fellowship program in Philadelphia who said, treat these just like the inguinal hernias, fix them the day before discharge. Or do you go ahead, worrying that you're in the honeymoon period, go ahead and proceed with urgent CDH repair because you might wind up on ECMO? So I'd love for 1 or 2 people to discuss about the urgent repair. Anybody willing to say, here's why I like to do it that way? Find somebody, Katie.
Come on, urgent repair. There's got to be somebody in here.
No, nobody's going to throw anything. We just want to hear. Okay. Oh.
Here we go, old trusty. Even if he doesn't do it, he'll give an argument.
So I don't do urgent repair, but I used to. And part of it was that you get the baby and they would be in a honeymoon period and you could do the repair without a whole lot of fanfare. And then what would happen over the next couple of days is that some of them would do great and some of them would just completely tank. And we've swung the pendulum completely back from one side where they were doing emergent surgery to the point that we're now all doing elective surgery. And to be honest with you, I'm not sure that there is as much difference as everyone thinks there is, but I do think that what we're doing now is very reasonable. And what we do and what's up there is that we actually follow them with echoes. So when their pulmonary hypertension has resolved, that's when we're doing it.
Yep. Great. All right. Well, if this baby does need ECMO, how are you going to do that? Bicaval VV, atrial VV, VA. Back in the old days, we only had one choice of cannula, and you only could do one thing. But so I'll open it up again for any of the VV advocates. Tell us about that. Obviously, somebody wants to worry about hypotension a bit, so we do VA, but any VV advocates? Oh, there we got one. Daryl?
Sure. Well, first of all, that chest x-ray looked like liver down. So if this kid's going on ECMO, then something there's going to be a reversible element to it, and so VV is going to be a great approach to reverse that. So at Texas Children's, Yinka and I commonly use the strategy of VV first, wanting to get oxygenated blood into the pulmonary vascular bed. And also every child will get better with as soon as you initiate VV. And if the worst case scenario, if you have to convert, you can also technically convert to VA if needed. And most won't, most can avoid carotid cannulation. However, we are kind of rethinking it based on some discussions during this conference, et cetera. And there may be, so what Yinka would say is, if this is a severe CDH, 40%, 30% liver up, immediately crashes after birth, like crashes into ECMO, VA is probably the best, and I think Dr. Kays might agree with this, is a good approach because it's going to be time and you have to have neonatal lung growth in order to improve. But in an infant where there's a reversible component of pulmonary hypertension because of fluid overload or other things that happen in the neonatal period, then I think VV would be a best initial approach.
Thank you. All right. Patient deteriorates and you cannulate for ECMO. Your recommendation regarding timing of CDH now is early repair on ECMO, repair after ECMO wean but before decannulation, or decannulate, get them stable, fix them day before discharge again. And the reason for VA at the front is if you do VV at 3 in the afternoon, it's always midnight when they want to convert to VA, so sorry.
Matt, we're going to need to hear from you.
Say again?
Yeah, so this is heartwarming to see this at 60%. I think Daryl made a lot of really good points about VV. I'll take maybe the opposite side because going on to VA is a setup for this, which best data would suggest that early repair on ECMO gives every child the best chance. There's really two predominant ways that people are looking at this now and thinking about it. One is everybody early repair on ECMO, and the other is maybe more of a hybrid or a risk-based approach where you take the ones that are the most severe of those that are on ECMO and repair them early, or you decide, well, they barely went on, they were, liver down, you put them on VA, we're gonna be able to get this kid off, or we think there's a high likelihood. I think the downside to that is if you err in that risk assessment, which we do at least 30 to 35% of the time, now you're late on ECMO, you're stuck, and you've missed an early window, which gave you a better opportunity to survive. But I think the real rationale for this is that the best data would suggest it's a better way to go. If you're on VV and you do an operation early on ECMO, that VV cannula moves all around. That's a little bit of a dangerous situation. With left ventricular dysfunction, if you're on VV, I think you risk having to convert to VA, which is an unenjoyable experience for everyone that has had that unenjoyable experience. So I think there's a lot of reasons that early on ECMO, VA, and early repair on ECMO all set you up for success down the line.
Thank you. Anybody in the latter group who maybe has had a bad experience with bleeding right after you fix the diaphragm on ECMO? And any comments from the I like to wait group? Okay. All right. Now you got to tell me how you're going to fix it. Is this going to be laparoscopic, laparotomy, thoracoscopic, thoracotomy?
Yeah, he's on ECMO, just imagine it. VA.
See, I've tried all these. Looks pretty clear cut, though. All right. Now, when you find a type C defect, we'll say that one was what this is, that you can't repair the diaphragm primarily, and that's your intraoperative judgment. Patch closure with a synthetic mesh, patch closure with a biological mesh, or make that muscle flap work. right. Can somebody holler out what's their favorite synthetic mesh these days? That's been a moving target. Anybody have a favorite? Gore-Tex, that's an older one. Dual mesh Gore-Tex, okay. All right, how about biological mesh? Anybody have a favorite? Katie found somebody.
For that 8%, right, the data are clear that a biological mesh is going to go away, so this is going to have a 100% recurrence rate. I'm totally curious as to why people would choose that. As an overlay, it would be great. Primary repair with a patch overlay, maybe that's a compelling thing to do. That's in vogue, maybe for minimizing recurrence. And the muscle flap is really interesting. It's gained a lot of attention. It's probably doubled if you look at the registry over the last, I'd say maybe 5 years, that a lot of centers have pivoted to trying this and like it, right? I know I see different centers around here doing it. The Children's Hospital Philadelphia group, I think, done it, has had excellent outcomes. Great presentation earlier today from the Colorado group about great outcomes. But I'd love to hear somebody's rationale for the biological.
Brian, your side of the room's kind of quiet.
We choose our words carefully over here.
We're sitting kind of
You could just stick that microphone in front of Gene or somebody over there and make them talk. So. All right. Gene, any comments since I called on you? No. All right.
Pat, sorry.
You've been doing this a long time, so I thought you might.
Sometimes the classics work, and when I look at my results over the years, the patch closure with the synthetic mesh has left me with recurrence rates way lower than what's out in the literature. So I'm sticking with it.
Mic drop, Katie. Mic drop.
All right, well, in this case, you were not able to close the abdominal fascia. You got the hernia reduced, but now you can't close the fascia. This is a dramatic picture, so pretend it's not quite that much sticking out, but you now are stuck, and you are trying to decide what to do with the abdominal wall, so patch closure of the fascia again, just close the skin, or place a silo, again, dramatic like this, and reduce and come back another day.
Yeah, still on ECMO. This is in the OR. At the time of the hernia repair, you just can't close the abdominal fascia.
All right, this one has fans in all categories. Patch the fascia, close the skin, come back another day. Choice of fascia, choice of mesh here. Whatever you used for the diaphragm, you just keep using it, or do you do something different?
Wound vac.
Okay.
I think wound vac is a great option here because it gives you access still to see if you had a bleeding complication, you've got a chest tube, you've got something in the abdomen, recognize it early. If you have fluid overload, you've still got the fascia open. I think it's a great liberal option.
All right, you place a synthetic patch on day 6, fascia. 6 weeks later, you see this. Looks like there's some pussy stuff coming out the medial aspect of the right upper quadrant incision. Sorry, pretend that's the left. What do you do? Course of systemic antibiotics, feel like you need to go back and excise the mesh or do some further workup and imaging? So most are going to try some antibiotics. Brian, do you mind telling us what happened in this case?
Yeah, so I know nobody in this room, other than me, has ever experienced this, but this is what's called a mesh infection. And I just want to do a little teaching here. That's bad. So I definitely chose A, and then I chose B.
All right.
And then how are you guys all liking those patch repairs of the diaphragm now? How are you liking that, Brian? So far, so good?
It's hanging in there. Yeah. We thought a lot about it. He still has his diaphragm mesh for now. We'll see if it stays in.
Potentially. Yeah, we do muscle flaps at the University of Utah for sure. We've been doing them, I think, forever.
All right, we're going to move on, and this one's a little tricky because you guys, most of you sitting here, just heard a lecture about this topic. So I'm going to sort of ask you to say what you would do, answer these questions as if it's last week instead of tomorrow. Y'all ready? You were asked to see a 4-week-old former 34-week gestation male infant in the NICU with a reducible right inguinal hernia. He is stable and nearing discharge. You recommend open hernia repair before discharge, laparoscopic hernia repair before discharge, discharge with a plan to do an open hernia repair past 55 weeks, or discharge and plan for a laparoscopic hernia repair past 55 weeks. Pretend you didn't hear Marty Blakely talk. I'm just kidding. All right. Interesting. Comments? The open hernia repair before discharge, a little passion there?
That's a lot of people doing laparoscopic inguinal hernias. Yeah, I agree.
Something? Somebody?
Got a comment over here.
I answered E, but that's, it depends on the patient really. And I know I went to the talk, and so I think I'm supposed to do D now, but it really depends on the patient, the family, how many anesthesiologists we have in our hospital right now, because we have no OR time right now. And so a little bit of that factors in as well, not so much for laparoscopic or not. If I can fit a baseball in the inguinal hernia sac, I'll probably do that open, but if it's much smaller, I would do it laparoscopically.
Thank you.
Same,
Yes.
same thing, I would just do it laparoscopically, but also, you know, it's a little bit different. We talked about rural surgery, patients in rural areas. It is really hard to get patients to come back, especially for me, I live near the border. They're not gonna come back, and so sometimes those social things you have to consider as well, on top of the fact of the gestational age and the medical issues with the kid.
Can I add on to that, Mac? In that last presentation, I was having a hard time understanding how the inguinal hernia goes away. Who can explain, like, what do we think is happening with that? Yeah, Daryl.
No. I have the same concern. Before we all run home and change what we do with the neonatal hernia, the preemie hernia, I'm concerned. Because I wonder, if you notice, there was 4% versus 11% resolution, and that hernia was defined by any clinician. It was only 71% surgeon. And I'm concerned that the resolving group gave a 7% avoiding surgery outcome in that group, which may have given the clinical benefit that made it statistically significant. And I'm concerned about that.
So,
I don't know if it goes away or if it just is no longer symptomatic and you can't see it. Remember, the most common adult hernia I still believe is an indirect inguinal hernia. May not surface till later. However, witnessed it multiple times, and it's hard to operate when they say, I haven't seen it in 5 weeks, 6 weeks. Come back in a month, still haven't seen it. Come back in 3 months, still haven't seen it. I'm not operating until they show me a picture or something else.
So one of my partners would turn the laparoscope around every time that he did a G-tube in a NICU baby or something, and he would often find hernias. And I, by contrast, would never look, no matter what. I'd close my eyes if they turned around. And he had a patient that he took back to do an inguinal hernia repair based on looking at this. He didn't do it at the initial time. He went back and laparoscopically it was gone. And so Daryl, I understand your concern, but I will tell you that at least in some percentage of patients that have hernias, they really do go away.
I've had a couple of experiences where I've operated on a little infant hernia, and while I don't always open the sac, there were a couple of episodes where I felt I wanted to, and in fact the sacs had sealed up, so when I opened the tip of the sac, it was just sealed. And I've had that happen a couple times, so I think that's what happens in some of these kids. And if you think of the physiology of a processus vaginalis, going away in utero, I imagine that's part of the physiology of that. But yeah, we've had some kids. In fact, we wrote a paper on it, right? So.
Yeah, and I think it also depends on what you define, like how you define an inguinal hernia, right? So in the U.S., it's a clinical diagnosis, so it's not like we're running around ultrasounding every neonate's groin. And so laparoscopically, sure, you see a patent processus vaginalis, but clinically, you know that patient doesn't have an inguinal hernia because you're there for a G-tube. So why repair those if you don't have to? So that's the other part of it is, one, how do you define an inguinal hernia? And then two, in our series, it was 68 infants who underwent delayed repair, and we had a 33% clinical resolution rate. And that was with the premature infants being diagnosed clinically with an inguinal hernia by pediatric surgeons and then followed by pediatric surgeons up to 2 years.
I think there's one in the back. Keep going back, Brian.
I got right here.
Okay, next.
My comment is based on the timing again. It looked like in the data presented that less than 28 weekers and those with BPD were the ones most significantly affected. And so in a 34 weeker stable, I don't know if that means he had BPD or not, but in the older subpopulation without BPD, that data did not look significant in what was presented. Whereas with less than 28 weeks in BPD, it did, but possibly looking at that data closer may help to inform this more too.
Thank you, Ben.
I was just going to reiterate what Dr. Notrika had said. I'd had a patient that I had done a laparoscopic pyloromyotomy, and I turned it around because I trained at Phoenix, and I turned around and I look, and has moderate bilateral inguinal hernias. I don't repair him at that operation. We bring him back a little bit later. And prior to the operation, I look back at the clinical images in his chart. I'm like, okay, yep, they're there. I stick the scope in, they're both completely gone. So.
Wow. How about a 16-year-old male presents with a reducible inguinal hernia? He's a football player. I think that's a Michigan helmet. I wouldn't have picked that one, I don't think. Open ligation, high ligation, laparoscopic high ligation, open mesh, laparoscopic robot mesh, or something else? Well, 3 strong. All right, great. Can we start with somebody talking about laparoscopic robot mesh in a 16-year-old? Again, those of us who are doing the 1-month-old and 1-year-old and 4-year-old and 5-year-old, and all of a sudden, where's the robot? I feel like I need to ask Gretchen, but maybe that's not fair.
I know PEDS SRC is working on this as well. Anybody here from that group? Any comments?
That surprises me a little.
That surprises me too.
Any comments? This would be, yeah, it'd be
One
great.
behind you, Katie.
So one of my partners, Sid Dassinger, is now doing a lot on the robot. We're working on adapting that. But in this patient population, we've decided that we'll put put a camera in. If they have an indirect hernia, we'll repair it just like we would any other one. And then if we go in and go, oh, we've got a direct defect, then we have the ability to convert to a TAP type procedure. And that's kind of where we've landed on that for right now.
That sounds ideal. That's awesome.
Yeah. Any other comments?
Anyone here fixing it with the robot?
So just real quick, this I think the last slide. When you fix that 16-year-old and he wants to know when he can go back to playing football, depending on what you did, I guess, go now, 2 weeks, 4 weeks, 6 weeks. When do you get to go back to full speed as a 16-year-old? Well, that's quite a variation, isn't it? 2 weeks, 4 weeks, 6 weeks, even somebody says tomorrow. All right, thanks everybody for your time and participation.